Intervention. I'm Stephanie from WorkSafe Tasmania and I'll be your moderator. In recognition of the deep history and culture of this island, we acknowledge Tasmanian Aboriginal people, the original and continuing custodians of the land, sea and sky. We acknowledge and pay our respects to all Tasmanian Aboriginal people, all of whom have survived invasion and dispossession and continue to maintain their identity, culture and Aboriginal rights. Please now take a moment to read the following slide about information received today. Please use the chat tab to type any questions that you have for today's presenter. Those questions will be answered at the end of the presentation. Only presenter webcams will be used and today's webinar is being recorded. It is now my pleasure to introduce today's presenter, Dr. Mary Wyatt. Mary is an occupational physician involved in policy development and research with the Australasian Faculty of Occupational and Environmental Medicine. Mary is dedicated to translating research into practical applications. Mary leads the initiative It Pays to Care under the health benefits of good work policy by the Royal Australasian College of Physicians, advocating for evidence-based practices in injury schemes. And we welcome Mary today.
Thanks very much, Stephanie. Appreciate the introduction. I always have to remind myself where to move these slides on. So today the focus is on identifying and addressing psychosocial factors early in work injuries. And I can see there, I'm sorry, the psychosocial is misspelt with an S at the beginning. And so I'm going to talk about how this can be done in a systematic way, what it involves, how it can be put into practice, and what are the potential outcomes. And it doesn't have to be exactly as this system is described today, but really that you are focusing on those early psychosocial barriers. Experienced case managers are pretty good at picking up barriers, but when we're not really experienced, it can be very easy to miss them, and us healthcare practitioners miss them all the time. And I'm going to finish off by just talking a little bit about the policy It Pays to Care. So to start off with a everyday health problem like a sore back or a rotator cuff shoulder problem, what we know is that psychosocial factors account for up to 80-85% of the factors that result in people staying off work. Now, psychosocial factors affect all of us. They're all our beliefs, our understanding of life, our attitudes, our coping abilities, what else is going on in our lives, our fears. So, we might want to go and ask for a raise. And but what will the boss say? What will I do if they say no? How will I cope with it? So all our kind of thoughts and feelings and approach to life influences how we behave and influences what we do and don't do. And this is such a rich area for psychosocial factors to play a role. And the system throws up stressors and people have to deal with all sorts of difficulties that make it more likely these psychosocial factors that are normal in our lives will make it harder for that person. So good data from New South Wales. This is the forerunner to the intervention in public hospitals. And so what they did is they measured psychosocial risk in people who've had a claim. And they did that within 1 week of them lodging the claim. Now, we know you can pick up psychosocial barriers the more a case goes on. So if you show most people a case and describe a case to them at 6 months, they could pretty clearly, with a rich description of what's going on, identify the psychosocial factors from the beginning. But the difficulty is at 6 months or 12 months, things have become set in concrete. It's much harder to disentangle things, and it's much harder to come back from psychosocial barriers mucking things up. So it's much better if we can identify them early. So here's the screening tool. The short form of REBRO Pain Musculoskeletal Questionnaire was the particular tool used here. And that shows that people have elevated risk. It's a score out of 100 from the short form of REBRO, the 10 questions. And those at elevated risk, which was determined to be over 50, had 3 times the amount of time off work than those in the under 50 score group. So it's pretty good evidence that you can identify these people with barriers early. And the other way of describing these results was for every 1 point increase in the score, the short form of REBRO score out of 100, there was a 4% reduction in the likelihood the person would be back at work when the study was done. So pretty good, what we call a dose response evidence. So the higher the risk factors, the lower the likelihood the person gets back to work. So they account for the majority of work disability, prolonged work disability. This applies in both claims, or physical and psych, but we just don't have as much data on psych cases as we do on physical injury cases. There's a lot of data on the short form of REBRO as a questionnaire, as a screening tool. It's been translated into multiple languages and tested out in different cultures and different settings in different countries. And it's well validated, and it can be done by phone or hard copy or electronic copy. So it's fairly, you've got different ways you can put it into place. So just going back to psychosocial factors, we've talked about them forever. Kind of doctors have a bit of an internal eye roll if you start talking about psychosocial factors, because we know they're there, but what do we do about them? Well, a big part of why we developed the PACE care policy, a lot of it is really bringing evidence to what we've known for a long time about how to look after people with work injuries. But this is new evidence, and it's important new evidence, and it's evidence from Australia where we are leading the world. The Americans are starting to pick it up. The Canadians are interested. So there's a lot of people looking at it because it's really makes a big difference. So the other important part of this equation is that the biomedical model just dominates. So the biomedical model says basically that if you have a condition, then you treat that condition. So you have a back problem, you identify that there's a facet joint problem, you deal with that facet joint, you inject it or mobilize it with physio or whatever, and then you fix that problem. But unfortunately, life isn't like that, and people are not just the components, they're kind of structural components. We are that, kind of not necessarily logical creatures. So we as doctors, very stuck in treating the physical condition model. What do? We send them for an MRI scan, we send them to physio, we tell them there's a disc degeneration, and and certainly in Melbourne where I'm based, then the model of care is you send them to a specialist, and they tell them, do more physio, or anyway, lots of interventions, over-treatment, over-diagnosis, and we introduce a lot of fears and worries about medical conditions the way we deal with things. So we're not good at it. We know there's some stuff going on, but we don't have the time. It does take time to understand psychosocial barriers, and more particularly, it takes time to address them. Studies have shown that GPs and physios identified about 5%, versus a brief screening tool. This was a different study. 70% were identified by a screening tool. And so once again, we miss psychosocial barriers until it's too late in so many situations. This is actually a repeat, I'm sorry, of the last chart, but I've included this slide to show you this other chart, which is the more flags, the more barriers, specific barriers identified as there, not just the score, the higher the risk the person will stay off work. No. Sorry, I do that again and again. So the data is showing that you can actually treat people in this situation. Now, this was a landmark study. It was called the Wyatt study. Workplace, I've forgotten the 4 letters, what it stands for, but basically a workplace-based early intervention model of care. This was done in New South Wales in public hospitals. They separated the hospitals into intervention hospitals and control hospitals. Everyone had screening within a week of their claim, and that was done by the insurance case manager by the phone. Those at elevated risk in the control hospitals just received usual care. Nothing different was done, just the usual way claims were managed, treatment was managed, etc. In the WISE study, what happened was people at elevated risk in the intervention hospitals had a 3-part intervention. Now, not everyone agreed to going to a psychologist, but all of these people were offered extra support by psychologists near the workplace. About 50% took that up. They were given up to 6 sessions with a psychologist with psychosocial counselling, and the psychologists were trained to do this to make sure they were doing it properly. There was extra support provided at the workplace by the return to work coordinator, particularly if there were issues at the workplace, if they were the psychosocial barriers or some of them. And they also had extra healthcare support. So in this particular study, they had a injury management consultation, which is a special type of consultation in New South Wales where you go and see a specialist, probably an occupational physician, and it's not like a medico-legal assessment. It's more about their capabilities and that everything's going, being done properly. And then they will speak with the treating GP. Now, what they did was focus on making sure there were 2 things going on. One was that the GP was actually using evidence-based healthcare, and that the GP was comfortable with the duties that were being offered and that they were appropriate, and that the specialist had confidence that they were the right sort of duties. So it's sort of like a reassurance for the healthcare provider or extra support for the healthcare provider. And what they found in this study, when they looked at the results a couple of years later, there was a substantial reduction in claims costs, which really is a proxy, I think, for suffering. I think claims costs are a rough measure of how things go. Things go smoothly, people are usually back at work fairly quickly with a common health problem. So what you see in the chart there is the red chart, part of the chart is the claims cost by month in the intervention hospitals with the high-risk cases that went ahead as part of the study. Remember, there was only about 50% of the group. So it's not all. The blue are the control hospitals where it was usual care. And there's 2 things. So you can see that the ongoing costs beyond about 10 or 11 months are higher in the control hospitals, and beyond 30 months in the intervention hospitals, there are no ongoing claims costs, so no long-term disability, whereas you still see a lot of ongoing costs in the control hospital people. So really pretty good evidence that this approach can make a significant difference. A couple of things. When you look at the end result numbers, they're not huge. They're enough to have good statistics, but they're not massive. And we do want to make sure that those who didn't go ahead with the counselling are not somehow very different from those who did go ahead to the counselling. So that was double checked, and they didn't look different in terms of their general profile or their screening profile, etc. I have included a link, so I think there's Stephanie's going to be sharing the PowerPoints, and there will be a link there to a video on the WISE study from Professor Michael Nicholas, who led the study, if you would like to learn more about what they did and their approach. Pretty good at pressing wrong buttons. So here's now a replication of the Australia Post study. In medicine, we like to see great results and important results, but we also like to see those results replicated in another study. We are cautious about when a study is done once off and those results can't be repeated. So it was very positive to see these results, similar results being found when Australia Post implemented the same approach. Australia Post, Melanie Jansen, who runs the workers' comp area of Australia Post, or the injury management area, I should say, of Australia Post, saw the results of the WISE study and went to Michael Nicholas, Professor Michael Nicholas, who's a well-regarded international excellent researcher, world-leading, and said, I'd like to do what you've done. And so with the help of Professor Michael, Melanie set up Australia Post to do this and set it up in a way which helped all of us. So it was set up in a way where there was control states and intervention states. So that was the only practical way to operate their approach. Now, they modified their approach. You can't necessarily find a local psychologist around Tennant Creek or somewhere in the remote Kimberley where Australia Post operates. So you couldn't necessarily bring in the same model of having local psychologists. So what Australia Post did was use their EAP provider, and a proportion of their staff were trained in psychosocial counselling to make sure they were doing it properly, and they were the group used. And what you can see here, so they started this in 2020, which, you know, they were planning some face-to-face, but it was COVID time. So fortunately, they switched to electronic and video, and that all worked out fine. And what you can see here is, so again, they used the short form of Rebro, cut-off score over 50, and they then were referred to the local counsellor, the local sort of EAP, so online counselling, video, telephone. Again, like the WISE study, high level of satisfaction from people with an injury. They like being asked these questions, these psychosocial questions. It's got to be set up in the right way, but they like being asked these questions. They feel they're being listened to as a whole person. They're very satisfied with the care they got. And what you can see here is I'm going to explain more about the system shortly and how it works. But what you can see here is when people are referred for counselling, what happens is you can't just counsel them generally. You really want to identify what their particular psychosocial barriers are. Now, common ones are challenges in coping and workplace issues. They're the two most common. And this is generally, I'm not talking about Australia Post specifically. And but there's a whole plethora, and particularly anxiety, particularly stress, and particularly pain interference. So what you can see here is a range of other questionnaires, along with the short form of Rebro, that have been implemented at the beginning of counselling and then at the end of counselling. And so what you're seeing is the pre and post measures. And over here is the short form Cerebro, which is done as a screening tool, but again repeated at the end of counselling. And the average score for the elevated risk group was 61. This might be too small for you to, hopefully you can see. And then the average post-counselling was 40. Now that takes people into the low risk group, which is just what you want. And then their results become like the low risk group. And what you can see is a range of other questionnaires that we use. So here's the DAS, the depression part of the DAS scale, which is about somebody's mental health. So 46% reduction in the depression scale in the DAS, 42% in the anxiety of the DAS, 31% reduction in the stress score of the DAS, improvements in brief pain inventory severity, pain interference, pain self-efficacy goes up 36%, which is just what you want. And then pain catastrophizing goes down. So all of those results show that you're really getting the care right. Another advantage of the system is that the results are measurable. Oh, almost press the leave stage button again. Capability. So what this is the return to work result from Australia Post. And what you can see here is there's a reduction in the time frame from when they opened the rehab case to getting back to any sort of work, big reduction in time to return to full hours, and a big reduction in any return to work to full hours. So progressing, well. And then costs. So similar to the WISE model, they had about just over a 30% reduction in incapacity costs. They were a little surprised at the reduction in medical costs, but what they thought when they looked back over what had happened was that they were getting in early and supporting everyone with what was good evidence-based treatment. So that instead of the injury management consultation in New South Wales, they would have a case conference with their rehab people and the GP at about 6 weeks or earlier, and they worked with the workers to get them what they need. So if they had, say, a knee problem with arthritis, they'd get on to, offered them a dietitian and offered them exercise physiology and got in early with proactive treatment. And they felt that with the sort of general support led people to using what was available more effectively and perhaps missing out on some of the operations because they got better with conservative sort of everyday care and also being responsible for themselves. So actively exercising rather than sort of, a bit demotivated and not really doing their exercises regularly. Australia Post says that they really felt their system was pretty good as it was. So to have a 34% reduction in claims costs has been huge for them. They were happy really with how they were going, but they do have issues with an ageing workforce. And a lot of people they've been there for a long time doing manual work. So and a lot of musculoskeletal problems. So, a challenging environment to get people back to work. So they're very pleased with the outcome, the results. This is being written up for a proper peer review study at the moment. It's in the research papers in preparation. So let's just talk a bit more about these systematic approaches and what they involve. And really, it's a 3-step process. If you, say, for example, wanted to introduce this at your workplace, then you would think about it like this. Now, if you're at a workplace of 50 people, then it might be a bit impractical to set this up as a routine. But if you're in a workplace, if you're in a public hospital or you're in a large workplace, it is worth thinking about how you might adopt this type of model. And I guess there are two important things. One is there are key elements you need to do. And the second is how you go about them is really quite flexible, and you can tailor it for your environment. We are developing a best practice guide for this type of work, but it's still probably a few months away from being released and being generally available, as we seek to get feedback on it from some people in the meantime. So the 3 steps. So the first is assessing your risk. For all the OH&S people, it's assessing your level of risk here. We want to rate your psychosocial, or put your workers' psychosocial risk. And so we want to make sure we capture everyone. We don't want to miss anyone. And so what that means in any screening is you want to have a high level of sensitivity. So if we think about ordinary everyday medical screening that you might be more familiar with, if you think about having a mammogram, well, that's a screening approach for women, every 2 years over a certain age. And that's not finding a diagnosis. So we know we look for an abnormality, but if there's an abnormality, we got to make sure we know the diagnosis. It's just a screening test. It's not a diagnostic test. So this is generally with screening in medicine. We do lots of screening. We might screen for high blood pressure, or we might screen for diabetes. Screening is about picking things up early when we can make a difference. There's no point in screening for something we can't treat or we can't modify the course of, but there is worth screening if we can make a material difference, and it's worth investing our time and costs in the screening. So the screening questionnaire is just that. It doesn't give you all the answers, but it tells you who you should be working with more. And when should you do screening? And screening is that test to look for who might be at risk. And then that will help you triage into risk categories. So, you might have heard the term when you go to the emergency department, you might be triaged or sorted into levels of how sick you are, so that people who have got urgent problems are seen quickly, and others who've got cough and cold are left to languish for many hours. And so we want to do screening. The gold standard screening tool at the moment is the short form of Rebro. It's the most studied, most well validated. You can develop your own, but it's a very long, complicated process, and you've got to test it out against other approaches or other tools. What you want with any triage tool is you want it to be simple. You want it to be as few questions as possible, but you need it to cover all the important areas. People need to be able to trust you to actually fill it out, and you would want it to be able to integrate into your system. So if you're, say, for WorkCover Queensland, and you're dealing with a lot of cases, they have a system where they can click and send a link to someone, and that will give them an electronic version of the short form, a Rebro. They'll fill it out, and that will be integrated into the case management database, and it will automatically score it. So that's nice and integrated. But in an everyday setting, such as a physio practice or a small employer or a medium-sized employer, you probably just have to have a hard copy and manually score it. And think about how you're using them. If you're not getting people to fill them out, how are you offering them to people? How are you introducing it? It's important to say to people that you want to understand all of them and how you can best support them with their recovery, and then do the best you can with the questionnaire. There's no one right or answer to each question, so that's the sort of a broad way you introduce it. And then, so you've got your elevated risk or your low risk group. Those in the elevated risk group now need a more thorough assessment of how you're going to evaluate what the actual barriers are in this person. And probably the best way to do that on a systematic basis is administer the questionnaires that I showed you in that slide for Australia Post. So the DAS, the brief pain inventory, the pain catastrophizing, etc. And a psychologist or a counsellor or someone with some degree of experience can do that, and then talk through with the person the results and delve, just having a conversation. You don't have to do the further questionnaires. So if you're, say, a physio in everyday clinical practice, or you're a return to work coordinator who's just got the short form of rebro and you're not all that cluey on deep and meaningful conversations and questionnaires, you can still use the short form of rebro and just say things like, the person might have said, I'm worried about being able to cope, or something to that effect. I'm not giving you the exact question, but you might say, tell me more about why you're concerned about that. And so just going through the questions and delving, you might start to get a sense of what are the person's issues. If you don't have a lot of experience in this area, the more you can do it systematically, the more likely it is to happen. And the more you can do it systematically, the broader the responses and the better off you'll be. But you don't want to just say, okay, I need to have it perfect to do this. You can still do it in other ways, less sophisticated, but, at least it's happening in some way. And then once we've kind of got a handle on what the person's barriers are, what we do then is match the support to that. So some people, their barriers might be they've got their elderly mother who's staying with them, who's got now fallen over and broken her hip or broken her shoulder or something. So she's at home, but she needs a lot of support. So you might say, well, what's that got to do with coming back to work? That's a non-work related problem, but could we do something practical to help that person? Could we, in some way help them work out what's the best way to get an aged care assessment, bring in other support, coach the person about how to ask family for support, modify the work situation with that in mind, but doing it with the person. So we think about what those person's barriers are and help address them. The most common barriers I mentioned before are low coping ability and workplace issues. And really counselling or coaching to help people with that is the most effective way. It is hard for people. They're often uncertain about what's happening. They're coping with pain and uncertainty about their condition. They may not be good at coping at the best of times. Their supervisor might be a pain in the neck. And they don't know how they're going to go because they reckon that the supervisor is going to give them duties outside the limitations, or it's not going to be helpful, or so-and-so's as a co-worker is going to be saying things about them. So coaching them and helping them work out ways through that. Really important part of psychosocial counselling is empowering the person. Like, it's a bit overused word, that empowering, but giving them agency, helping them get that they have a role and that they can be self-directed, and supporting them with that. And then that helps motivate them to do things like their exercises or follow through or talk through how they'll deal with those issues when they go back to work. So it's really about matching the care if there are workplace issues, engaging the return to work coordinator, bringing in the managers if things aren't going smoothly, talking to the managers about how to help the person. So really whatever is needed to support the person. So just a little bit more detail. So I've said a fair bit of this already. As few questions as possible, engendering trust, better to be done as a structured process, as business as usual, and integrate it. The thing is, repeat it. If you think if it's normal, but after a few months or even a few weeks or whatever, you think things are not going smoothly, repeat it. Don't hesitate, jump in and repeat it. One organisation who really has a high level of looking after people is New South Wales Fire and Rescue, and they do it every 3 months. So they say the conditions a lot of their fireys face, particularly troublesome PTSD, can take a long time to come good, and they do it every 3 months as a routine. Mental, physical health problems, they want to pick up any extra problems as early as possible. So don't hesitate, repeat it if you need to. Here's some of the other screening tools. I haven't given you reference for all of these, but you can find them online. There's many to choose from. This is a conversational tool, probably, they're all pretty reasonable, although, as I say, the short form is probably the most flexible and available. Some set the risk rating level lower, such as 46. Some set it at 48, but 50 is probably the most common use of the cutoff score out of 100. This is what the screening questionnaire looks like. It's the longer version is 20 questions. This has got 10 plus an extra, how long have you had your pain, etc. And then it's scored. Some of the questions are reversed, so you just got to go through manually or have it done in an automated fashion. So when I was talking to you about questioning and going into depth, going back to that, so if somebody has scored up here 8 out of 10 level of feeling tense or anxiety, you might say to them, what's making you tense? What's causing the anxiety? What can we help you with? And similar with the other questions, tell me a bit about your physical activity making your pain worse. And then the psychosocial assessment, the range of questionnaires, so passive coping predicts disabling pain. People are more likely to report their pain is so bad they can't be doing things. Emotional distress predicts pain intensity and disability. Catastrophizing predicts long-term pain intensity. Low self-efficacy predicts medication use. Fear avoidance predicts long-term work disability, and perceived injustice predicts delays recovery and return to work, and work perceptions predict work disability. Just all the range of tools and what they predict. It's really probably overkill to tell you all of this, but they do predict certain constructs. The thing that you're looking to pick up with your screening is distress. And so you're really looking for some sort of distress, and then you're really delving down into what is causing that distress. And there might be lots of things, or only a few things, or only one thing. And the questionnaires plus the structured assessment from the structured interview from e.g. the psychologist or counsellors, the most efficient and effective. Clinical assessments miss problems all the time. We judge things automatically. We don't necessarily realise it. But it seems to be when people complete questionnaires independently, they are better. We just get a better identification of the particular problems with the broader range of questionnaires. We get a measurement of the result, which we can repeat later. It's done independently of our judgment. The person filling out the form owns it. And that's really important. As doctors, we do a terrible job. I've done a terrible job trying to talk to people about psychosocial barriers. You start to talk to people about them, and they just seem to, you can see them thinking, the doctor thinks it's all in my head. But there's something about written questionnaires when the person themselves writes it down. And so what you can do in that setting is take it out, take their questionnaire out and say, here I see you've marked stress up here as really quite high. And what we know is that stress will influence your situation in this and this way. And so it's a much more connected and targeted approach where the person can take ownership for it because they've declared they've got this issue in the first place. And that ownership can really make a massive difference in terms of how the person then takes on and addresses their problem. It standardizes things, and that's really useful if we start to look at broader measures, not just the individual, but this approach generally, this approach as a service, and being able to understand the effectiveness of the approach. And so there's lots of different questionnaires that can be used. So, for example, catastrophizing, pain catastrophizing, or the coping strategies can be used. But it is good if we could get some kind of consistent use of questionnaires, because it would allow us, as this field develops, to be consistent and then better measure results. So let's talk more broadly about psychosocially informed intervention. So we've talked about the screening or risk rating. We've talked about the assessment process of a broader suite of questionnaires and the person being interviewed to go in and talk more about what their particular psychosocial barriers are. Let's talk about now how we address those barriers. So what we've found, what we know, is that psychosocial counselling can occur in a range of settings, as can general counselling. So we know that distress interferes with a number of situations, not just work injuries. And what we're seeing sometimes now is even for cancer treatment, there might be a psychosocial questionnaire, and before surgery or before cancer treatment is started, they help the person address these barriers and fears so that they're better positioned to undergo their treatment. And so I'm just trying to tell you that this is not just in work injuries, that you can have a psychosocially informed intervention, but it is a particular area where research has developed and we are learning about it. So what we want to do is we want to help people with behaviour change approaches, we want to help them with self-management skill development, we want to help them with graded activity, matching their work rate readiness, and we want to help them across many domains. So you've got here this sort of framework for doing this. Now, there's a lot of people who can provide psychosocial counselling, but we can't necessarily rely on all different professions to provide psychosocial counselling. And some will be better at certain types of counselling or counselling for different things. So physios might be better to counsel about fear avoidance behaviours, whereas a psychologist or a counsellor with a mental health background might be better to be counselling about building self-efficacy and using value-based goals. So there's no one right profession. It depends a lot on availability, but these are the important skills we need. Now, in both the Australia Post and the Wyatt studies, they had up to 6 sessions with a psychologist, and the average was 5. So it's not long-term counselling, it's not deep and meaningful counselling, it's short-term focused counselling. Other aspects of implementation were, as I mentioned before, the psychologists near the hospitals were engaged in the Wyatt study, and remote ones for the Australia Post study. There's obviously a need for confidentiality in these settings. And so the general approach was the psychologist didn't need to provide any feedback if there was nothing that needed to be done by other people looking after the person with the injury. So let's say there was a workplace issue. They worked in an Australia Post outlet, and going back to that was problematic because of the other person at the outlet. Then with the worker's permission, the psychologist would report that to the rehabilitation case manager or the return to work coordinator. They don't have return to work coordinators at Australia Post. They have rehab case managers. It's the national Comcare system as their self-insurer. And so the confidentiality was like that. Only communication if there needed to be. Otherwise, if it was an issue with coping with a teenager on drugs, causing a lot of distress, there was no need to report that to Australia Post as the organisation. Ditto for the New South Wales study. I've mentioned about the extra healthcare support, and then that extra support for the GP, either via an injury management consultation or a case management conference. And the Australia Post people said they had high levels of trust from the GPs because they were helping the worker, and that makes just so much sense. I have a lot of people saying it's the GP because they're certifying people unfit for work. Absolutely. There's a lot of certification of people who are certifying people unfit for work when they really do have a capacity. And often GPs are protecting the patient. So if there's psychosocial barriers, the worker doesn't want to be back at work, the doctor will often protect the patient. Data from Victoria says that only about 26% of GPs trust the employer will actually stick to the return to work plan. That's a pretty low level of trust. It might only be, this is Victorian data, so it doesn't mean it's the same in Tassie, but it is a big issue around the country. So if the doctor's not sure, they'll be reluctant to push the person back if the workplace is not trusted. And of course, you know how these things go. We only need one negative experience. We remember the negative experiences. So you might have 5 positive ones where the employer's okay, and then one where they're negative, but that really damages the trust for everyone. In terms of the framework for care, big international review of the literature about 5 years ago from Canada and Australia, all the studies, what helped people back to work. And what they found was workplace health and case management, service coordination, when you had all of them working well and doing what they should, excellent chance of person being back to work. When you only had 2 out of the 3, you're starting to kind of, you still had a reasonable chance, but you are losing some of it. And when you only had 1 out of 3 or 0 out of 3 on board, your chances of return to work were very low. So evidence that we really do want to have a good system for really addressing all areas of return to work, all those domains. And so you can have varying levels of sophistication. I think it's worth talking a little bit about other alternatives. So some private insurers in Tasmania and elsewhere are using a modified version of this. The Navigator Group has been around for a few years now, and they provide early psychosocial counselling. That's part of their core business through the Navigator Support Program. And their model is, well, they will either do the risk rating or triage screening, or the organisation themselves can do that. And so with some claims in Tasmania, there's a threshold for if the person's off work for 2 weeks, they're referred for the option of psychosocial counselling with the Navigator Group. And so it's kind of used in a different way, and the results we've got are not necessarily, not at the moment in peer-reviewed papers, although they're working on that, but they are then providing that psychosocial counselling without necessarily integration with other parts of the scheme, like with the workplace and healthcare. And their model is absolute confidentiality, and they say that helps build trust in the system, but that prevents integration with the other components. We don't know how much difference that makes. At the moment, we don't have the data to compare just counselling versus counselling and the other additional approaches, the workplace and healthcare. So we hope to be able to do that over time to compare and understand. So back to what you can do. Well, it depends, again, as I talked about earlier, on the size of your organisation. You can provide basic support and help out with common sense options, as I've alluded to. You can help the GP try and identify psychosocial barriers. If you identify distress, you might try and refer locally for mental health support, psychologist, counsellor. Some workplace rehabilitation providers have training to do counselling. If you wanted to, become familiar with the short form of Rebro, learn to use it yourself, try it out on a few people, discuss it, talk to others who might be using it, gradually build up your learning with that, delve using some of the questions. Sorry, just going back to that last slide. So as you become more familiar with it, that will help you, let you decide, do I want to go further with this, or do I want to put some simple things in place so I've got expertise who can help me with it? And now, so there's a few minutes at least for questions. I'll just quickly move on and tell you a bit about It Pays to Care in the last couple of minutes. So it's policy from the Faculty of Occupational Environmental Medicine. Some of you may be familiar with the Health Benefits of Good Work policy we wrote in 2010. This is a deeper look at work injury schemes, and really two things drive us. Outcomes are worse in compensable schemes for the same condition, which is just crazy, and being out of work long term, which happens to a disproportionate number of people in workers' comp, is bad for people's health. There's an evidence-informed policy paper. It's 180 pages. It sounds like a lot, but it's not a difficult read. I would encourage you to read it. It provides the evidence. It provides an overview of the policymaker's role, case management, the workplace and healthcare. It looks at the different areas here. There's a values and principles-based paper talking about the underlying values and principles of healthy insurance schemes. Again, really important. And here is some links. Now, I'm sorry, I haven't included a link to It Pays to Care, but if you Google It Pays to Care, you'll come across our website. Look for us on LinkedIn, follow us on LinkedIn. We've got regular updates we're providing, infographics, ongoing information. And here, if you want to learn more about this topic of early psychosocial triage and match care, there's a bunch of recordings here for you on our sister organisation Anzon website. Feel free to learn more. And if you'd like any information, don't hesitate to be in touch. So I'll hand over to you.
Thank you, Mary.
There are any?
Thank you. So our presenter today is Dr. Mary Wyatt from It Pays to Care and the Royal Australasian College of Physicians. So if anyone does have any questions for Mary, please use the chat tab to type and submit any questions. Today's webinar has been recorded, and as Mary mentioned, we will also provide today's attendees with a copy of her presentation.
Thanks for the feedback for those who've put them in the chat.
So there are no questions coming through, Mary, so I'll begin to wrap up today's presentation. So thank you again to our presenter, Dr. Mary Wyatt from It Pays to Care and the Royal Australasian College of Physicians for your webinar, From Risk to Recovery, Effective Strategies for Early Psychosocial Intervention. Today's webinar has been run as part of WorkSafe Tasmania Month. WorkSafe Month is an initiative that is funded by the WorkCover Board Tasmania. Please head to worksafe.tas.gov.au to see what other events we are running during the month of October. Today's webinar has also been recorded. Please head to WorkSafe Tasmania's YouTube channel to rewatch today's webinar and view other webinars that we have been running throughout this month. Thank you again to our presenter. Thank you for everyone for attending, and please have a safe and healthy rest of the working day.